Good. So, good afternoon. My name is Gero Mayer. I'm a master optician and an independent clinical partner of Swiss from Germany. Today, I would like to share a clinical case that illustrates the therapeutic potential of scleral lenses. This is not a product presentation, it is a clinical case about ocular surface healing. These are typical patients I see in daily practice. What you see are advanced ocular surface disease, recurrent epithelial defects, post-surgical corneas, and eyes that no longer respond to conventional treatment. Some patients do not suffer from a lack of treatment options, but from a lack of effective biology. At this stage, adding another drop, another device, or another procedure rarely changes the outcome because the problem is no longer therapeutic intensity. It is biological insufficiency. Without a functional tear film, the cornea loses its ability to regenerate. At this point, epithelial defects are no longer transient. They become persistent. And every blink adds mechanical stress to a biologically compromised surface. Why standard optical solutions fail? Well, standard optical solutions are highly effective as long as the ocular surface is functional. Glasses and soft contact lenses rely on a stable tear film. Rigid corneal lenses correct optics, but they do not treat the ocular surface. Artificial tears may support epithelial healing indirectly, but they do not provide growth factors, immunoglobulins, or physiological signaling. And surgical options address structure, not epithelial homeostasis. So the problem begins when the surface itself becomes the limiting factor. In severe ocular surface disease, standard optical solutions fail for very specific reasons. An unstable tear film leads to fluctuating vision. Any mechanical interaction occurs on a compromised epithelium. There is no protection from desiccation, and there is no continuous delivery of biological mediators. This is not a failure of optical correction, it is a failure of the environment. The case. This is a 5-year-old girl with Riley-Day syndrome, a condition characterized by severe sensory and autonomic dysfunction. This means she has no pain sensation, almost no tear production. And at the age of 5, she had already undergone 9 keratoplasties. The absence of pain is not protective. It is dangerous. Pain is a biological warning system. Without it, mechanical damage goes unnoticed. Epithelial breakdown progresses silently. This is why the child repeatedly injured her own eyes. She scratched them without realizing the damage. Her fingernails had to be removed. She even bit her fingers. So this is not only a corneal problem, it is a problem of missing biological feedback. When I first saw her, the cornea was not failing because of lack of treatment. was failing because the environment was unstable. Have a look at the picture. And this was the condition on day 1. What you are seeing here is a persistent epithelial defect. The staining is dense, diffuse, and stable, not fluctuating. This ulcer had been present for months and did not respond to conventional therapy. Importantly, this is not a primary corneal disease. This eye had already undergone 4 penetrating keratoplasties. The last graft was relatively fresh, and despite that, epithelial healing failed. So we are looking at a 5-year-old patient with a non-healing ulcer on the 4th graft. At this point, we decided to fit a scleral lens, not primarily for visual rehabilitation, but to change the biological environment, and the lens was filled with autologous serum. Just let that sink in for a moment. So in this case, the scleral lens is not a visual aid. It is a therapeutic delivery system. If the problem is not the optics, but the environment, then the solution must change the environment. The lens creates a stable microenvironment. Protection, hydration, and continuous exposure to biologically active fluid. So the key mechanisms are a stable fluid reservoir, mechanical protection, and constant bioavailability, and minimal epithelial stress. This table is not meant to be read in detail. It illustrates that autologous serum is biologically much closer to natural tears than any artificial tear substitute. Autologous serum provides growth factors essential for epithelial healing, immunological components for surface protection, and a physiological osmolarity. In other words, it does not only lubricate, it supports biological regeneration. Some artificial tear substitutes are marketed as regenerative. From a biological perspective, they are not regenerative. They are supportive at best. They improve symptoms, but they do not replace missing growth factors, immune mediators, or neurotrophic support. Autologous serum does not mimic tears, it replaces what is missing. This is the situation after 1 week of continuous wear. It was the first week in which the cornea was no longer exposed but supported. We already see a clear reduction of the epithelial defect. Not because we corrected the optics, but because we changed the environment of the cornea. The epithelium finally had the chance to heal in a protected, biologically active setting. After 2 weeks, the epithelial defect was closed. There was no need for additional surgical intervention. The surface remained stable under continuous protection. And at this point, the goal was no longer to initiate healing, but to maintain a stable biological environment. After 3 weeks, something remarkable happened. The patient was removed from the transplant waiting list, not because we planned it, but because the corneal surface stayed completely stable. There was no recurrence of epithelial breakdown. This tells us something important. The healing was not transient, it was sustained because the environment was stable. At this point, the scleral lens filled with autologous serum was no longer a temporary solution. It had become a long-term biological support system. And maybe the most important outcome, at least for me, for the first time, the girl could go on holidays. She could finally attend kindergarten, and she was able to swim in a pool like any other child. Yet, 10 years later, there was no recurrence, no new epithelial defects, no further keratoplasties, no emergency interventions. This case did not succeed because of optics. It succeeded because the environment was permanently changed. In severe ocular surface disease, stability is success. The picture is quite recent, so I was very fortunate to see her and see that it's in such a good condition. This case is not about a rare disease, not at all. It is about a common problem we see in severe ocular surface disease. Severe ocular surface disease is often labeled as end stage, but in many cases, the tissue is not irreversibly damaged. It is biologically unsupported. Healing does not fail because therapy is insufficient. It fails because the biological environment is unstable. This case shows that biology requires continuity, not intensity. No aggressive intervention, but a stable, protected environment over time. Scleral lenses are not just optical devices. They allow us to create a therapeutic environment, mechanically protected, hydrated, and biologically active. When we change the environment, the tissue can recover, even in cases that appear unsalvageable. So, what does this mean for daily practice? This is not about doing more, it's about doing things differently.